Our first speaker of the day is Dr. Ainie Soetanto. Dr. Soetanto is currently attending vascular neurologist who joined Maimonides Medical Center in December of last year. She's an assistant professor in the Department of Neurology at SUNY Downstate Health Science University and also associate program director of education at SUNY Downstate Adult Neurology Residency Program. She trained at Albert Einstein College of Medicine and Montefiore Medical Center for both med schools, neurology residency, and vascular neurology fellowship. From 2018 to 2023, before she joined us, she was attending physician and faculty at Montefiore Medical Center, where she was the director of education for the vascular neurology department. Besides clinical neurology, her career interests included medical and neurology education, post-stroke epilepsy, and a study of psychiatric manifestations of stroke and other neurological diseases. Please welcome Dr. Ainie Soetanto.
Hello, thank you all for being here today, and thank you, Tony, for your invitation for me to speak. I am very excited to speak to you about the hot topics in stroke care that were highlighted at this year's International Stroke Conference 2024, which was in Phoenix, Arizona. When I was asked to give this topic, I thought, wow, 30 minutes, how can I cover everything? So I chose to speak about what I thought was very interesting, and also the publications that were simultaneously published at the time of ISC. I have no disclosures. So here's my outline today. So I'll be speaking about two highlighted studies in the plenary sessions, the Zodiac study and the STOP-CAD study. And then most of my talk is going to be reflecting one of the hottest debates that were highlighted at ISC, which is ISC and cryptogenic stroke, and where do we stand today after the results of the negative Arcadia trial. So Zodiac stands for 0-degree head positioning and acute large vessel ischemic stroke. I guess what I decided to do was write you a line of all the hot topics each day, but in red is what I'm going to be speaking about. If I had more time, I would stop here and read these to you. Okay. So the question that the authors asked was, does 0-degree head positioning of LVO thrombectomy candidates associate with greater clinical stability and or improvement compared to 30-degree positioning in the pre-thrombectomy period? This was a multi-center prospective randomized outcome blinded evaluation, or a probe clinical trial. And patients, upon being decided to be a go case for thrombectomy, were randomized to either 0-degree or 30-degree positioning. And then an NIH stroke score was calculated every 10 minutes from beginning until the time that thrombectomy was being performed. The primary outcome was early neurologic deterioration of at least 2 points on the NIH stroke score scale prior to thrombectomy. Their secondary outcomes were severe neurologic deterioration, which was defined as worsening of at least 4 points during head elevation without improvement after positional change. They also looked at the incidence of hospital-acquired pneumonia, all-cause death occurring at any time during the 3-month enrollment period. It was an intention to treat analysis, and enrollment halted early when the efficacy boundary was crossed, which was when they reached 92 patients. So what were the results? This was actually pretty profound. So patients in the 0-degree head positioning were found to be significantly less likely to have deterioration of at least 2 points, with a number needed to harm of 1.88. Similar effect was seen when looking at the severe neurologic deterioration category, which was at least 4 points, with a number needed to harm of 2.48. Interestingly, the thrombectomy outcome was the same between the two groups. The TICI scores were equivalent. Now, despite the equivalent TICI score, there was still a clinical effect after a thrombectomy. So there was an improvement in an stroke score at 24 hours in a 0 degree as compared to the 30 degree. And this persisted at 7 days or at time of discharge. However, this did not translate to the MRS score at 90 days, unfortunately, but the authors noted that their study was underpowered to make this conclusion. The authors' conclusions were that 0 degree head positioning is safe, it imparts stability in the pre-thrombectomy period, and they suggested this be a rescue procedure to stabilize patients prior to the point where they get the thrombectomy, which is really important in situations where the thrombectomy center is not nearby, right? So a lot of time might go by between arrival to the ED and then the ability to thrombectomize. Okay, so changing to the STOPCAT study, as I mentioned before, this was a simultaneous publication, so it was worth mentioning briefly. So the authors compared the risk of ischemic stroke and major hemorrhage, or ischemic stroke risk and major hemorrhage and cervical artery dissection treated with antiplatelet versus anticoagulation. This was an important study because until now, we didn't really know what to do when patients presented with cervical artery dissection. Our results were based on 2 big trials in the past, which were the CADIS trial and the TreatCAD, I think that's what the other study was called, where there was really no difference between antiplatelet therapy and then AC. So in this study, they did an observational retrospective study to include what they called real life scenarios, right? Patients who were treated with any combination of these therapies, which were chosen at the discretion of the clinician for various reasons. So they included cervical artery dissection without major trauma. They looked at the anticoagulation group, which included any of the anticoagulants listed there, versus antiplatelets, which could have been monotherapy or dual therapy. And dual therapy was mostly clopidogrel with aspirin. Their outcomes were subsequent ischemic stroke and major hemorrhage. It was an as-treated approach. And they did a lot of exploratory analyses analyzing the difference between the various antithrombotic regimens. So briefly, so results of the patient characteristics and the decisions for the clinicians to choose one antithrombotic over the other. They found that women, white individuals, and those with partially occlusive thrombus, unsurprisingly for the thrombus part, right? They tended to receive anticoagulation more than antiplatelets. Whereas Asian patients with intracranial dissection and those who underwent endovascular treatment were more likely to receive antiplatelet therapy alone. The bottom line result was that individuals with cervical artery dissection treated with anticoagulation had increased risk for major hemorrhage at 180 days, but no other differences were observed at any other time point for ischemic stroke or hemorrhage risk. In their many interaction analyses, they found that occlusive cervical artery dissection was associated with a lower risk of ischemic stroke. And therefore, they concluded that the study cannot exclude a benefit of anticoagulation over antiplatelets in ischemic stroke risk following cervical artery dissection, particularly in patients with occlusive dissection. And then if anticoagulation is chosen initially, it would be reasonable to change to antiplatelets before the 180-day mark to lower the risk of major bleeding. Okay, so now we're going to shift gears completely and speak about this debate of cryptogenic stroke and ESIS and where do we stand today in 2024. This was a highlighted debate, including many exciting speakers, including Dr. Kamel, Dr. Kasner, Dr. Katsanos, and there were several others whose names escape me. I apologize. So brief introduction to why this really matters to us today. The TOAST criteria is something that hopefully all of you are familiar with. This came out in 1993 as an attempt to categorize the various mechanisms of stroke. So these were 5 main mechanisms: large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, including etiologies such as dissection or vasculitis. And then this cryptogenic category, the stroke of undetermined etiology, which had 3 aspects of the definition. Either 2 or more mechanisms were identified, for instance, small vessel disease versus large vessel atherosclerosis. A negative evaluation consisting of studies that were chosen at the discretion of the clinician, and then the least satisfying part, which is the incomplete evaluation. They did not specify exactly what diagnostic studies were necessary to be able to put these patients into one of these categories, especially regarding the cryptogenic category. They said diagnostic studies should exclude potential sources of cardiogenic embolism, but did not specify if they required long-term telemetry monitoring or TEE, et cetera. And then in 2014, a more defined definition for ESUS came out, which is embolic stroke of undetermined source. So the first several points are similar to the prior TOAST criteria, or actually, no, they're not. Number 2, they specified that the vessel imaging, both extracranial and intracranial atherosclerosis, did not reflect, or it was symptomatic only if it was greater than or equal to 50%, in which case they would call that symptomatic intracranial atherosclerosis. So before calling it ESUS, it could not have flow-limiting stenoses. No major risk of cardioembolic source of embolism, and no other specific cause of stroke identified. So with the ESUS definition, the authors did list which diagnostics they require to be able to formally call this ESUS. So note that this specified, obviously, brain imaging, a 12-lead EKG, precordial echocardiography, aka TTE, cardiac monitoring for at least 24 hours, including automated rhythm detection, and then imaging of both extracranial and intracranial arteries by any of these modalities. So here is the conclusion paragraph from the original 2014 study, where I highlighted a very important point here, which became the basis for the subsequent trials that I'm going to go through, where the authors wrote, the validity of ESUS must ultimately be justified by the response to therapy, e.g. anticoagulation. So very briefly, so these were the 4 studies that we have that looked at AC and ESUS. Number 4 is the Arcadia study that was published this year. Let's see. So I have a slide on each one of these. So I'm just going to summarize this. So the first study, the Navigate ESUS study, looked at rivaroxaban versus aspirin, and then the effect or the rate of recurrent stroke versus hemorrhage. The bottom line is that they found that rivaroxaban was not superior to aspirin in the prevention of the recurrent stroke after ESUS, and then it did have a higher risk of bleeding. And then you ask why. So where is this effect? Why not this effect of AC versus antiplatelets? And above are the listed couple of the reasons why. So the dose they chose for rivaroxaban was 15 milligrams, though the dose that we use clinically is actually 20 milligrams. So the authors rationalized the 15 milligrams by saying, or they defended the 15 milligrams by saying that they wanted to offset the risk of hemorrhage. Interestingly, against the definition of ESUS, intracranial vessel imaging was optional. So in each of these groups, 22% were without vessel imaging. Number 4, this is a big one. They excluded patients with current or planned implantable loop recorders. So they effectively excluded the patients that probably would have benefited from anticoagulation the most, right? Those that clinicians felt were more probable to have AFib. They also looked at patients with PFO. They excluded patients with PFO planned for closure, therefore probably excluding patients who would have benefited from AC, right, with the high-risk PFO features. They did not look at those features in the study. There was a long time between the index stroke to randomization of 37 days, excluding patients or excluding the patients who probably would have had recurrent stroke more likely right after the index stroke, right? So we see that phenomenon. And this was terminated early for the conclusion that I listed there. Note, patients with LA left atrial enlargement, particularly about 10% of the patients with ESIS and a large left atrial diameter, appeared to benefit from rivaroxaban for secondary stroke prevention. The next study, Respect ESIS, was a similar study looking at dabigatran, 150 milligrams BID, or the reduced dose if you met criteria for age and creatinine clearance versus aspirin. This one did require intracranial vessel imaging. It did not exclude patients with long-term telemetry monitoring. About 14% of patients received this. And then the medium time to randomization was about the same as the prior one, and the result was similar. Dabigatran was not superior to aspirin. Though the incidence of major bleeding was not greater, there was more clinically relevant non-major bleeding in the AC group. And then years went by. Atticus attempted to hone in on the patients that were more likely to benefit from AC, right? So patients who had enrichment factors with at least one predictive factor for AFib or PFO, including a certain size for the left atrium, and I forgot the other ones at the moment. Cardiac monitoring was required, and nearly everyone had this. They had a very short median time to randomization of 8 days. And then, unlike the other ones, instead of using clinical stroke as the endpoint or the outcome, they used MRIs to look for new ischemic strokes as a surrogate for the clinical stroke, and it was terminated early. However, this was a negative study, as you know. Apixaban was not superior to aspirin. And then finally, our Arcadia trial. This one did try to define an atrial cardiopathy with more diagnostic criteria. So these are the ones that were listed here. They tested apixaban versus aspirin at the appropriate clinical dose. About 15% were diagnosed with AFib at median 30 weeks, which is in line with cardiac studies, observational cardiac studies, which found that about 20% of patients with long-term telemetry monitoring eventually find AFib. And unfortunately, there was a high rate of participant withdrawal. So with the negative study, one of the big points that the authors made was few patients met this criteria of the elevated left atrial diameter, among some other limitations that they listed. But I'm going to move on for the sake of time to talk about, so what does this mean, right? So this is the brain thinking cap that we all wear as clinicians. The bottom line is ESIS is heterogeneous, right? So it's not just occult AFib that's causing embolic strokes. It's non-stenosing carotid plaques, aortic plaques, patent foramen ovale, silent MI, LV dysfunction, malignancy. What's very important to note that each of these etiologies are of a different mechanism. They may mandate different management than oral anticoagulation. I'm going to go through each one of these very briefly. Just an example of how each of these can cause embolism, right? So this was a study in 2012, which I thought had beautiful results here. So this study looked at patients with ESIS and carotid stenosis, looked at if the ipsilateral artery had non-stenosing carotid plaques, and what did the contralateral artery look like. So attention to the coral-colored wedge. There are different types of carotid plaques, and the pink represents type 6, which is where you start seeing these vulnerable high-risk plaques, defined as there's a thrombus on it, there's an ulceration, a ruptured fibrous cap. And you saw this, or they saw this, in the ipsilateral carotid artery in 38%, and they saw this in 0% of the contralateral artery. So this is convincing evidence, right, that non-stenosing vulnerable carotid plaques could be the source of ESIS. This is just a nice chart I wanted to add for clinical learning, that if you're trying to identify these vulnerable plaques, just one vessel imaging may not be sufficient here, right? So CTA would not necessarily capture fibrous cap rupture or lipid-rich core. So clinically, think about doing more than one vessel imaging. And don't forget, in these other studies, when they talked about intracranial vessel imaging, they said any vessel imaging would do, not multiple. So in terms of treatment-wise, let's see, here we go. So this is an old trial, just as an example of how they compared AC versus aspirin, and there was no benefit specifically. They looked at warfarin. There was no benefit of warfarin over aspirin, and there was higher vascular death and MI. But this was prior to the era of other medical aggressive medical management, including statin therapy for aggressive lowering of LDL. Aortic plaques. So similarly, no great studies that concluded that warfarin was greater than antiplatelets. An ARCH study in 2014 attempted to study this, but it was inconclusive because it was underpowered. Socrates trial, just one example, which I'm using to highlight the fact that antiplatelets are more likely to be effective than AC, where they compared aspirin versus a more potent antiplatelet ticagrelor, and there was a difference in outcome in risk of ischemic stroke, and here they included aortic arch atherosclerosis, so that was useful for this point. PFO. So PFO, you all know that the standard of care now is closure versus medical therapy for select patients. And there hasn't been clear data about which is more effective, AC versus antiplatelet. There is some suggestion that AC is a little bit better, but currently there is no guideline as to you must do AC over antiplatelets. This one is very interesting, silent MI and LV dysfunction. So specifically about silent MI, there was a study by Merkler in 2021 where they looked at patients without prior MI or stroke, followed them over a period of 10 years by EKG, and then they found that silent MI was independently associated with subsequent ischemic stroke, more profound with overt MIs in the short term and long term. And then very fascinatingly, when they divided the cause of ischemic stroke in secondary analysis, the association between silent MI and stroke was limited to non-lacunar ischemic stroke. So you couldn't make the argument that they just shared high-risk vascular risk factors and therefore a lacunar happened. So this was nice evidence towards silent MI being a possible source of ESIS. Malignancy is another one. So malignancy is a little bit difficult because a lot of our studies are extrapolated from venous studies. There hasn't been great trials yet looking at AC in arterial ischemic or AC for those with malignancy and arterial ischemic stroke. But interestingly, Canadian stroke best practices recommendations in 2020 say that AC could be considered over antiplatelets, and when AC is used, low molecular weight heparin is preferred. So this just suggests that we must go beyond the classic definitions of TOAST. And think about how there's a lot of overlap between the definitions, and we shouldn't just stick with the classic definitions that were originally proposed. This is a nice figure in Dr. Kamel's paper in 2019. In the same paper is this figure, which I love, which shows you on the left side of the oval, the stroke etiologies that they posit are more likely to benefit from AC versus the right side is antiplatelets are more likely to benefit. And then there's overlap between these. So I hope to have convinced you that ESIS is very heterogeneous. We can't just target AC as the therapy to end all recurrent strokes from ESIS, though that was the hope of the original TOAST paper, right? Or not the TOAST paper, it was the ESIS paper. Lastly, here's a clinical consideration. How about mixing? How about doing both anticoagulation and an antiplatelets to target both sides of the oval, right? So there was a COMPASS trial as an example in 2017, which looked at the combination of low-dose rivaroxaban and aspirin versus full-dose rivaroxaban. The combo group did result in less ischemic stroke than aspirin alone. Rivaroxaban alone did not do better. And the subgroup that benefited the most was ESIS. Though there was an increased bleeding risk with AC, not surprisingly. So conclusions. ESIS is heterogeneous. The definition of ESIS that we use is too broad right now, and that heterogeneity is not well captured in these trials that we have. The non-AFib etiologies do not clearly benefit from AC, and this is so important because tailored secondary stroke prevention is the key, right, to preventing strokes in ESIS. Let's consider further diagnostics. How about TEEs for more people, a malignancy screen? TEEs will be what enables you to look at aortic arch atherosclerosis, more PFOs, left atrial characteristics. And I forgot to put up a slide of one of the nicest TEE papers by Dr. Katsanos from a couple of years ago, which showed that once you put TEEs into the mix of diagnostics, that it does change management. It picks up abnormalities in about 50% of patients versus those without TEEs. These are all ESIS patients. And then it changed management in about 15 to 20% of patients, in that clinicians gave AC or antiplatelets. I think more AC than antiplatelets based on the results alone. So we need to consider this combination therapy, right? Perhaps in patients who are less vulnerable to hemorrhage. Thank you very much.
Anybody has any questions in the audience, or check the online Q&A session? And stop sharing, then we can see any questions. Okay, so no questions? Yes, go ahead. Please come to the microphone. I'll send the mic to you. Introduce yourself, please.
Gary Friedman from Brookdale Hospital. You mentioned anticoagulation versus antiplatelet therapy. What about the role of dual antiplatelet therapy? Would that give a considerable advantage?
Thank you.
Right. Specifically about ESIS, you're asking, or in general? So we all know for non-ESIS, right, we have this proven benefit of DAPT for antiplatelets. In all of these studies, they really lumped them together. So in most of these studies, they lumped them together, mono versus DAPT. And if I remember correctly, there was not a difference when they do sub-analyses of one or the other. I mean, theoretically, sure, especially if the thought behind the ESIS might be more plaque related, right? So that's where I would consider DAPT. What I would do in a practical clinical sense would be to look at what were they on before the stroke. So if they were on mono antiplatelet therapy before, then maybe those are the patients to consider DAPT in, right?
Turn on, yeah.
Hello. Thanks, Ainie. This is Nuri Jacoby from Maimonides. So I saw that the trial that showed a possible benefit of combination antiplatelet and anticoagulation was from, I think, 2017. In what clinical scenarios are you utilizing that right now?
I have not utilized it yet. And that's because I personally have such a fear of hemorrhage risk, right? These are patients, when you're talking about ESIS, these are patients that have more likely large territorial strokes, right? So these are strokes where I am especially concerned of the hemorrhage risk. So I have not been convinced yet to try this strategy of AC plus antiplatelet. I could be convinced eventually with more studies, but personally I have not. This was a thought a couple of years ago in a lot of clinical practice of, let's say someone has intracranial atherosclerosis and cardioembolic risk factors like AFib, right? A lot of people have both. Some clinicians did give AC plus antiplatelet in these groups in the past. And then I think it was AHA guidelines that highlighted, or that placed forward guidelines a couple of years ago that said that when you have a cardioembolic source, only AC is indicated over antiplatelet therapy, and part of that was because of the hemorrhage risk. So clinically, I have not done that, but I know clinicians that have.
Annie, you have a question in the audience online. So did the Zodiac trial impact how you provide care? Are you implementing a protocol that supports the, can we scroll down for the question? Just for patients who are eligible for endovascular therapy.
That's a discussion to be had with our group. I think it's really exciting data, and yeah, we have yet to talk about it.
Yes, I think we should. We should discuss and implement. Oftentimes, these are program-wide initiatives that we need to have consensus on and implement, certainly. I do, I think maybe we have a couple more minutes. I do have a comment and also a question for you, Annie. Excellent talk and really great review of a lot of topics in a short span of half an hour. Thank you. That's really job well done. In one of the ISC studies that actually, even though they show no benefit between anticoagulation or anti-platelet therapy, but their subgroup analysis looks like those who have left atrial enlargement seem to have 10% as showing benefit. And I think that highlights the importance of patient stratification, patient selection for specific cohorts to really be able to identify the signal or the side effects. Now, what do you think that's the reason? Are those patients are more identified with AFib? That's the anticoagulation benefit we're seeing with AFib population, or something else with those left atrial enlargement patients?
So you're saying, are you asking which are the markers that are more predictive of AFib out of all of them?
I'm asking, what do you think the benefit is coming from for those large, large atrial enlargement patients? Where's the anticoagulation benefit is coming from? Are they because they have silent AFibs, we're anticoagulating them? Because we know AFib anticoagulation is beneficial. Hopefully that's the case. We'll ask Dr. Wang the question.
I was going to say, right, and the next AFib talk is probably more suitable to answer that question. Yeah, no, I could give you guesses, but yeah, I could give you my thoughts, but honestly, I think that's a great question for the next speaker. Yeah, why LA dilatation? Maybe, yeah, no, I don't even want to try.
Okay, thank you, Annie.